In a moment, I'm going to invite onto the stage a man who really needs no introduction. He really is. You heard me say this man is a heavyweight in his field. When you want to talk about systemic change, this man understands what it is. Ian Smith, our keynote speaker, is talking about achieving systemic change. He is the chair of the NHS Surrey Heartlands Integrated Care System, a non-executive director of the UK Ministry of Defence Strategic Command, leads large-scale system transformations. His former roles was chair at King's College Hospital, CEO of Rees Elsevier, Taylor Woodrow, Excel Logistics, senior advisor to the UK Cabinet Office, Peace Initiative Advisor for Israel-Palestine in 2010 to 2012. A huge background in corporate leadership, public service, and global diplomacy. When you're talking about the NHS, you need someone who really is a master at what he's talking about. Ladies and gentlemen, please put your hands together for our keynote speaker, Ian Smith.
Thanks. I didn't hear any about Israel. I wanted to hear about my distinguished history. So I can't see too well. Anybody here? How many people here work in the NHS or in health and care? Yeah, we got some people in here? Yeah. Good. Okay, so what I'm going to try and do is stick to about 25 minutes. And I'd really like to open it up for discussion and hear your views. Because whether you work in the NHS and social care or you're an unpaid carer, the NHS and the health of this nation is as much about you as it is about the professionals and the clinicians. Because we're all engaged in this, which I'll hope to show you as I talk. This is what I'm going to say. So what I'm going to say is we've got fantastic clinicians, you know, some of the best and most caring in the world. We have some very good managers. We have 4 of the best biomedical universities in the world, in Oxford, Cambridge, Imperial, and having been at King's, I would include King's ahead of UCLH. And we have a system that is free at the point of need, so it's a universal system, yet we have some of the worst health and social care outcomes in Europe. I think the reason is a lack of leadership over many, many years that has created a fragmented, disjointed system, which makes it extremely difficult for managers to manage and for patients to flow through that system in a healthy and good way. I think what needs to happen is devolution, so that clinicians and managers are directly in contact with patients and residents. And I think we need to hugely reduce the amount of noise that comes from an over-centralized and micromanaging organization. The 10-year plan in the NHS will come out tomorrow. I'm hopeful that it will have some good things in it, and hopefully some of the things I'll talk about this afternoon. I think there'll be probably far too much aspiration and far too little concentration on implementation. The NHS is brilliant, the politicians, at coming up with great plans, the 5-year forward view, the 10-year plan, the shining city on the hill, but we get disappointed so often at what actually happens. So that's what I'm going to say. I'm going to talk a little bit about my views of where we are going, where we've gone wrong in the past, and where I think we should go in the future. And as I say, I'm going to be fairly brief because I would like you to participate. So despite all of those things, skilled clinicians, very, very caring people, pretty good management, free at the point of need, we have some of the worst health and social care outcomes in the developed world. Mel Brooks, the famous playwright and comedian, was recently asked when he reached the age of 96, what is the secret to living long? And he said, don't die. Unfortunately, in the UK, we do not have a good record of keeping our citizens alive. It isn't only, as I'll talk about, it isn't only about the clinical care you receive, it's also about our society and the lifestyle choices that many of us make, which I'll talk more about. In 1948, when the NHS was set up, it was really world leading, and it was fantastically fitted to the epidemiology of disease and social mores at the time. It was a system of district general hospitals. It was a system of distributed, often single practice general practitioners who treated minor illnesses, and in particular administered antibiotics discovered by or isolated or discovered by Alexander Fleming at St Mary's Hospital in London in 1928, which at the start of the Second World War was isolated by Florey and Chain. And throughout the Second World War, the industrialization of the production of antibiotics was accelerated, particularly in a laboratory in Peoria, Illinois. And a crucial function of the GPs back in 1948 and still today was to dispense antibiotics. They were a real wonder drug. So it all made sense back then. The epidemiology of disease was very different. In 1948, people would usually die at about the age of 60, and usually within 6 months of their terminal illness. Separating health and social care was not a problem because people didn't age. And mental health, we had a very different societal approach to mental health back in 1948. Rather tragically, and as we would now feel, quite alarmingly, we locked up a lot of people. So back in, actually as late as the 1960s, we had about 150,000 people locked up in mental asylums. Today we have about 15,000 secure psychiatric beds. The problem is that mental health has not gone away. And in fact, in many ways, it has increased through lifestyle problems, social media, and so on. Yet we haven't got the community care that you would need to put in place if you're going to let people, quite rightly, take people out of institutional settings. And that's a very different picture from the epidemiology, from the population, the demographics today. Today, somebody born today will probably live till the age of about 80, but they will live the last 10 years of their life in poor health, with comorbidities, chronic disease, increasingly living with dementia. We've had a big increase in lifestyle diseases, although smoking has decreased. There's still about 20% of the population who smoke. Drugs are a problem, both prescription and illegal drugs. Obesity is a major problem now, probably the biggest cause of cancer, ahead of lung cancer now. So although we've advanced in many ways over the last 70 years or so, certainly in terms of how we look after ourselves and each other, it's got worse. And the way we manage the NHS, which made sense in 1948 when Nye Bevan set up the National Health Service, it was a central run system. Before that, it had been very fragmented, lots of charities, private organizations. And what Nye Bevan did was to centralize that, make a national health service. And quite surprisingly, in hindsight, it was this was very deliberate. It was based on a Soviet central planning model. I'm not saying that to be insulting of the system. It's very, very clear in the literature of the time in 1948 that it was set up as a Soviet central planning system. The view in 1948 was the Soviets had won the Second World War, which is largely true, and that their system of central planning would be the wave of the future, and we needed to copy that in the way that we set up our NHS. Clearly, that has not served us well, and the problem is we still have a very centralized Soviet-style top-down management of the NHS. Of course, the Soviets discovered that it wasn't working for them back in 1991, but we've yet to realize that in the NHS. And things have, in many ways, have got worse, and especially since around 2010, the increase in poverty and the increased cost of living over the last 15 years, and especially 5 years in terms of the cost of living, as I said, the damage of things like social media and obesity, bad food, is really beginning to overwhelm an NHS system that just was not designed to cater for that. And that sort of Soviet vicious circle of what you do if you've got a failing health service, if you're Secretary of State for Health, well, you come up with targets. That's what the Soviets used to do in their planned economy. If that doesn't work, you put in lots of regulation, and of course regulation, if used well, is really important, but if used badly, it becomes a bureaucracy, box ticking, it becomes a huge distraction from real patient care. If that doesn't work, you reorganize. We're going through yet another massive reorganization of the NHS as I speak, and also local authority organization as I speak. If that doesn't work, blame management. You know, they must be asleep at the wheel. We should fire them. We should withhold bonuses, or we should pay them less. And you get increasingly, as I'll talk about, an unmanaged system. And if that doesn't work, then blame the clinicians. Jeremy Hunt having a go at junior doctors. And even now, you know, suggestions from the government that they're just not working hard enough. The consultants are not doing enough operations. The GPs, you know, have got their feet up at lunchtime at the pub and not seeing enough patients. And if that doesn't work, go back to back to the start and put in a bunch of targets. And that's the sort of vicious cycle that we've been in for the last probably 40 years or so. It is a hugely complicated system, but nothing has been done to make it less complicated. I mean, it's a fragmented system, overlapping jurisdictions. This is a typical healthcare economy, about 2 to 3 million people, a few acute hospitals, probably in a healthcare care economy this side, probably 200 GP practices. And the patient journey through that is awful. The patient gets wrapped around, sent from pillar to post like a pinball, and does not get the care that they need, despite, as I say, clinicians and carers and managers who really do care about their patients. It's hugely underinvested. It's been one of the big problems of being in public ownership. It's very much based on getting as low a cost as possible, putting CapEx into RevEx to meet the numbers. And therefore, we have a hugely underinvested estate, probably 1/10 the number of MRI scanners that Japan has. And this makes it increasingly expensive to run a system because of the money and the penny pinching that we've done over the last 20 or 30 years. And this over-regulation that I mentioned, creating far too much emphasis on assurance, oversight. I mean, the number of assurance and oversight meetings that I have to go to, the pages we fill in. For anybody in the NHS here, if you've seen the latest book on annual appraisals and how much you've got to fill in, then you would understand just how bureaucratic this system is. And what all of that does, and especially the problem of social care, which has been underdeveloped, ignored for so many, many years. And if we're not looking after people and their health and preventative care, especially the most vulnerable in our society, then they will deteriorate and they will end up in the National Health Service. So we create this pressure from society all turning up at A&E, getting stuck in hospital because there's no social care or support for them to get out of hospital, and 1 week in an acute bed for a frail elderly person living with dementia, they will lose 10% of their muscle strength and they will never get that back. It is literally a death sentence. Ambulance calls, I'll talk about that in a minute. Overwhelmed ambulance services, overwhelmed GPs. For any of you who've been in an A&E recently, just chaotic, overwhelmed A&E. And for our hospitals in Surrey and Sussex, 98% of our bed days are what's called non-elective. So those are mostly frail elderly or mental health who are stuck in hospital because there is no or insufficient social care or community care to get them out. The answer, I think, is devolution to accountable or integrated care organizations. I think we need to push accountability, responsibility as close to the patient as possible. In the private sector, this is exactly what you would do, because you do not survive unless you look after your customer, because somebody will come along with a better offer. And so push authority as close down to the patient as possible, and give managers the space, the managers and clinicians the space to do the best by their patients. So we'll see what comes out tomorrow. But accountable care organizations based on the trust, on the hospital, but with a complementary, as I'll talk about, a complementary community offer, so that we're beginning to address all of those out-of-hospital pressures that I described, which are creating such havoc and distress within our hospital system. In Surrey, we have what we call the Critical Five, which is designed to try to address these issues. The first is finding urgent care pathways that do not end up with an ambulance and do not end up at accident and emergency. In the south of England, our ambulance services have done some analysis, and they have discovered that there's only 13% of the times that they attend a 999 call, 13%, is a real emergency, requiring 2 highly skilled paramedics and a very expensive ambulance. I go out with our ambulance service every couple of months and I see it daily. We should not be looking after this patient. This should be covered by social care, by primary care, by community care. We should not be having an ambulance turning up. And 50%, although 13% are real emergency calls, category 1 or 2, 50% of the time that patient will end up at A&E, join the queue in A&E, probably get admitted because there aren't any other places that the ambulance can take that patient to. So we have a threadbare urgent care environment at the front door, before the front door of the hospital. So too many people turn up at A&E and get stuck there because we're not managing the back door and getting people out as quickly as possible and reducing the harm that they suffer. Safe and effective discharge then. As I said, 98% of our hospital days are non-elective bed days. Probably 30% of those patients should not be in hospital, and therefore they are suffering that harm that I talked about. We've never really had, we have it in some parts of the country, but not enough, a high-risk care management program. This is our critical 3. There's only 1% to 2% of the population who are really high risk and vulnerable individuals. Most of those are frail elderly or acute mental health or people with chronic disease. Yet those people bounce about the system. We don't have a joined up pathway for them. We need a high-risk care management program that identifies that 1% or 2%. And we know who they are, because they are the people turning up at A&E, waiting for GP appointments or getting stuck in hospital or calling ambulances. Identify them and then put in place a full cycle of care for that patient so that they are being monitored and cared for continuously, probably with a GP at the apex of a pyramid, designing the care plan, and an MDT care plan, so it includes social care. It includes loneliness, for instance, which is a major problem in the health of people. We do it in one or two places in the country, but certainly not universally. But it is done in the better healthcare economies. In America, the Partners Healthcare, now Brigham Mass. In Massachusetts, a program I tried to bring over to Bromley some years ago, where they identify the high-risk individuals, they put in customized care plans, it's a full multidisciplinary team that's looking after them, and they've published their data, and it reduces A&E attendances by about a half, and the patient outcomes are much better. We need in-hospital management that is good. I mean, most hospitals actually do provide pretty good care, but once you're in a hospital, the priority is to obviously have very good care in the moment from the clinician, but also to move the patient as quickly as possible to put them in a safer out-of-hospital environment. We have some very good metrics. Probably the NHS folk in the room will have heard of Professor Tim Briggs, who's done a fantastic piece of work over the last probably 10 years, actually, that benchmarks best practice on in-hospital care around the 20 or 25 specialities that are found within a hospital. Tim can be quite a cranky bloke for any of you who've anybody come across Tim here? He can be quite a cranky bloke, but he's really done a fantastic job at identifying what good practice is in hospital, what is best practice, and benchmarking best practice within hospital. And then the fifth of the critical five is looking at the whole system, which I'll talk a bit more about in a minute, and managing across hospital groups and across areas. We've had far too much individual hospitals quite jealous about the other hospital down the road, insufficiently coordinated, often resisting, and this is resisted also by individuals, by citizens, and especially by politicians. Save my local hospital, don't take my stroke unit away, mobilize that. A major program, just to give one example of the importance of making those choices, there are huge economies of scale in terms of clinical scale. So we know that bigger clinical units produce better outcomes. To use just one example, in 2010, London had 30 different stroke units throughout the city. That was after a hugely difficult program taking about 5 years to persuade the hospitals to give it up, to face down the local politicians, to get through the pickets that the politicians had put up to protect our stroke unit. 30 went down to 8 with a 25% improvement in morbidity. So it saved 25% of lives. And it took 5 years to get it done. My brother was involved in it. He was chief executive at Imperial at the time, Ruth Cornell, Bruce Keogh. But the trouble they went through to get that consolidation, because of all that noise, it took 5 years. And there's still so many clinical activities that are too subscale in maternity, in cancer, and many of them still in Surrey, I hate to admit. And we really need to just say, this is the data, this will improve life expectancy, you will do this, and you politicians and citizens who think you're saving your local hospital, you're actually harming people. So they're the critical five that we're pursuing in Surrey, soon to be Surrey and Sussex, as we're merging with our next door county. But it's not just what happens in hospital, it's not just the emergency flows and so on. The key finding, I think, and the most important piece of work in the last 20 years was a chap called Michael Marmot, who published a really influential paper in 2010 that said when somebody is born, their life expectancy and healthy life expectancy, only 20% is dependent upon the NHS and social care. 80% of their life prospects are to do with education, employment, community. And that really revolutionized our view of what we should be doing as a country in the health service. Yes, we need to get things right in the NHS, but the NHS is going to be increasingly overwhelmed if we don't address what Michael Marmot called the wider determinants of health. And we're making some progress in Surrey and in some other parts of the country. The council, I don't always talk well about the council, but the council have done a very good piece of work where they identified the communities that people associate with. Typically 50,000 people around the towns and villages in Surrey. And our objective with the local authority is to mobilize those communities, get more self-help, more peer support, mobilize the voluntary community, and then wrap health and social care services, particularly the GPs, into those communities of 50,000 people, so that we're really we're animating much more self-help, much more joined-up care, much more holistic care, looking at all the needs of that patient within that high-risk care management program that I talked about, so that we're improving the health of the population, because that cannot be done by the NHS alone. It can be done a lot by social care, but that is in very bad shape. So we identified the 29 towns and villages. We are beginning to re-engineer those public services around them. The GPs are crucial. A typical primary care network, as they call it in the NHS, is about 50,000 people on the list, which is a cluster of GP practices. Putting GP at the center of that is really crucial, because if you're just doing this community stuff and you've got local councillors getting involved, people think this is just a talking shop. But once you put GPs into the center of that, that's something that citizens really value and want to coalesce around and have the opportunity to be then educated in eating, smoking, drinking, lifestyle, and so on. And these are the neighbourhood teams that we are developing, and hopefully tomorrow we'll hear in the 10-year plan that these will become complementary to hospitals, to the accountable care organisations within hospital, but we will be creating these neighbourhood teams, typically of about 50,000 people, that are mobilising you, citizens, to get involved in your communities and to start caring for each other and ourselves in ways that will not bankrupt the country. And these are around employment, education, focusing on the most vulnerable in our society, and really creating that energy, which in so many parts of our country has really declined. I mean, this is a big societal problem, that our communities have been undermined. We've over-centralised in Westminster and Whitehall. We've taken huge amounts of power off local authorities. But we need to decentralise that system and make it complementary to this activity and really focus again on communities. Because that is the thing that is going to improve the health of our population and take the pressure off a hugely beleaguered NHS. And just to conclude then, the task of management within the NHS is to participate in these community groups that I've talked about, but also managing the flow of patients through this. There are different organisations, each with their own statutory responsibilities, often with their own board of governors or board of directors, who optimise their part of this system. And as soon as we do that, we sub-optimise the whole. So we need to move to a system where we can say, you will do this, we will improve social care, we will measure the impact of social care on ambulance call-outs, on A&E attendances, GP access, delayed discharge. And if we do that in the context of mobilising communities and people to start taking care of themselves and each other, and not getting wasted on a Saturday night or taking drugs or eating bad food, then we are going to get further and further in distress. So the bottom line is, you matter, all of you, whether you're working in health and care or an unpaid carer, you really matter. Because without you, we are going to get more and more distressed, And what we also need is leadership from the NHS, from politicians, and from local community leaders to begin to fix this. Thank you very much. So let's have a discussion. What do you think?
So Ian, I'll start with a question.
Okay.
And I've got some questions, but, really, this is the time. If you've got some questions on your heart, we can factor that in. We don't have much time left, but really want to just get some truths from...
I'm not going to let you out of here unless you ask at least 3 questions or make 3 points. So the deal?
So one of the things I want to talk about, really, so we've talked about the NHS. We've had governments try to fix it and just complete ineptitude. Yeah, we've had a joker for a prime minister who lied his way through office. Not much seems to be changing at the moment. We understand it's a bit of a dinosaur. So have we ever had the thought of just strapping the NHS and finding a modern equivalent and taking a model from elsewhere?
I think we've definitely got to take models from elsewhere. As I said, if you go to Holland, Scandinavia especially, you will find a lot of what I've talked about already happening. And it's interesting, they have been supported by politicians. I think the problem in the UK is that we've got such an adversarial approach. So when a new government comes in, they scrap everything, even the good stuff that was going before. I think you, the electorate, are responsible for this as well. We fall for empty promises and elaborate schemes. We've really got to hold our politicians to account for delivering, together with defence, which I'm involved in as well, so I feel passionately about that. But probably the most important thing in all of our lives, the health and well-being, our health and well-being, and those of our relatives and friends and population. So, and I think the politicians have got far too much into, we'll give you everything, we'll lower your taxes, vote for us. And by the time we find out that we haven't spent enough capital to keep our hospitals in good shape, then some other buggers got to pick it up. So I think our political system has a big fault to play. I think the other part of it is this over-centralisation. I think the Whitehall and Westminster politicians love to get power in there, but this is a £200 billion system, just health and social care, and it cannot be managed by the stroke of a pen from Wes Streeting or Jeremy Hunt or whatever.
So surely one of the big issues we have in NHS is that it says that we make all healthcare free for everyone. Now surely it's the definition of free that we need to really be clear on, because if you have an NHS that is overrun, an NHS that is archaic and old, an NHS where you've got people waiting on beds in corridors and hallways, we've all heard the horror stories, yet people that are making bad lifestyle choices willingly are sometimes filling those beds. How does that work?
Well, I think, again, government has got to, lay blame here. I mean, we have the highest rates of childhood obesity in Europe. We are setting those children up for a terrible, terrible life. And it's just unacceptable that has been allowed to happen. And too often, because the food companies, lobby government not to legislate against them. We just can't put up with that. We are damaging children's lives without them knowing it. And government, sits back and says, no, nothing to do with us. We've really got to start supporting government in making difficult decisions, which is, to improve the diet of people. Now, I'm sympathetic, for a poor family, when it's cheap, you'll eat it. But we've got to find a way of looking after particularly the poorest 20 or 30% of our population. As I said earlier, poverty has hugely increased. It's been a big problem in terms of putting extra strain on the population. Social care has been cut by the Tories in 2010, as much as 40% in some areas. I mean, these are very poor people. To qualify for free social care, your net wealth, that's including your house, has to be less than £23,250. Your house, your savings, everything, and then you'll qualify for social care. So we are failing the most vulnerable in our society, and it's a fool's journey because those people will become very expensive in the way that the health service, quite rightly, looks after them when they deteriorate and when they get ill.
Another thing when we talk about free, when we're looking at gender reassignment or full cancer treatments and rehabilitation interventions that are available for free, anyone within the UK borders, how do we protect the risk of people who are not in our borders coming across and having free health?
Yeah, well, we do charge people. Actually, I used to, when I was at King's College Hospital, I used to go around to the beds, actually, and who weren't citizens. And it's pretty tough, that, frankly, because these people are in distress. It's not a huge problem, frankly, if you look at it in the greater scheme of things. We don't spend a huge amount of money on it. But I think we do need to start getting incentives. And this is hugely controversial, and I'd like your views again on this. For people who do not turn up for their operation at hospital and keep an expensive team of 10 people, probably a theatre team of 10 people, and an empty operating theatre because they've overslept or whatever. I think we've got to start giving incentives. If you turn up at A&E on a Friday or Saturday night, drunk or drugged up, and you've spent 60 quid. My daughter tells me you don't need to spend 60 quid these days to get drunk. Yeah. We've got to start disciplining people because they are abusing the system. Not everyone, of course, but there are abuses of the system, and they're abusing all of us because they are taking care away from the people who really need it, the frail elderly, acute mental health. So it's highly controversial, but I would like to see some charging, frankly, or at least tell people what it costs. If you turn up at A&E and drunk and you're still there 10 hours later as you sober up, people need to realise how much that costs. Whether we then go on to charge them, it's up to the electorate.
Ian, tell us, what is that? What is that cost? Let's say someone here has got an operation, they don't turn up for whatever reason, like you say, you've got a team of 10 waiting. What does that look? What cost is that to the taxpayer?
So it's probably an A&E attendance, if it's for a long time, £4,000 or £5,000. The cost of a hospital bed for a frail elderly person for a week will be about £4,000 or £5,000.
Goodness.
For mental health, you can start getting really, really expensive for very troubled people, especially children. If you need 3 or 4 24-hour care for a suicidal adolescent, and we'd all agree, you need that. But I tell you, that is an extremely expensive stuff. So if we can get ahead of that and start treating, especially mental health, much earlier and at much lower cost, then we will save cost and, of course, huge distress for that person later on in their life or later on in their journey.
Thank you, Ian. Ian, how do you balance strategic oversight with operational realities when you're talking about systemic change? How do you balance that?
I think we should have a smaller number of metrics. I mean, certainly within the system, the 4 key things I really want to know: am I doing things that will reduce ambulance call-outs, and that 13%? Am I doing things that will reduce the pressure on GPs so that people can get to see them? Am I reducing attendances at A&E? And am I getting a hospital that is the only people in it need hospital treatment? And can I get them out of the hospital? And it can be done. I spent some time at Erasmus University Hospital in Holland a couple of years ago, and I was at King's. It's about the same size hospital as King's. I mean, these are big, complicated entities, the hospitals, 1,200 beds at King's and at Erasmus. 35 operating theatres. I mean, it's another point about management, undermining management, which the government often does, or senior management does by being micromanaging, does not help. These are complicated businesses to manage, and we need to support managers in their management development Management development for the average NHS professional is terrible. I mean, in the private sector, people would be on management development courses throughout the year, every year. In the NHS, these people are thrown in. Often the cuts of particularly service managers, middle managers, takes things out. It's no way to treat managers in what is a highly complex system. But in Holland, they look after the managers. They care about, they really focus on managers and how they can help clinicians do their jobs, because the clinicians really care. That's why they go into the profession, the nurses and doctors and carers. But in Holland, a similar size hospital then had half the number of A&E attendances at King's. King's probably has 400 A&E attendances a day. In Rotterdam, that was down to about 200, because they had fixed that out-of-hospital environment. Created polyclinics, urgent care treatment centres. In fact, they fined GPs who would refer inappropriately to A&E.
Oh, wow.
Which really motivated the GPs not to refer to A&E. They've got proper social care systems so that people are in care homes or in domiciliary care cared for. And the result is half the number of A&E attendances, running hospitals at proper, what is a safe capacity utilisation of 80% instead of the 98% that we run them in the UK. So it can be done, but you've got to have a small number of metrics, put the real responsibility down to the clinicians and the managers at the shop floor, and cut out huge swathes of bureaucracy at the upper levels.
Ian, I want to say thank you so much for your time. I know you're a super busy man, but I know you're very passionate about what you do. Thank you so much for your time. Ladies and gentlemen, please give a round of applause to Ian Smith.
Thank you very much. Great, thank you.
Thank you.